Good morning, good evening to our Indian
And
colleagues and Dr. Manjunath and Dr. Jaya and our Indian faculty and our audience. Welcome from Mount Sinai. Morning time here with the change in hours now. For us is
yes,
8:30 was 7 was 9:30 now. It used to be 8:30 before. And welcome from Mount Sinai Catholic with Dr. Keeney, my left side, and my fellows on the right side with Isha and Gaurav. So this is a very interesting case, and just want to show we continue to show additional cases with various important points in terms of management of patient. This is a little different, and that's what happening. Many patients with the heart failure have a coronary artery disease. I think this is a field which need to take its own toll, just like we call it a chip. Patients with a complex coronary disease. I think patients are with a heart failure who have coronary artery disease, and they are mislabeled, misdiagnosed, and so. So with that note, Dr. Manjunath and Dr. Jaya, we start our presentation here from Mount
yes,
Sinai. This These are our both myself and Dr. Keeney's disclosure, and both you, the pioneer, Dr. Manjunath, actually the one of the top center, the busiest center in India, performing all types of interventions. And I know that today you'll be showing us a tricuspid valve case. But
yes, sir.
so glad, and of course you have sent some of the fellows. We still continue about two fellows
No,
from India every year. So appropriate one bright candidate who has done USMLE. We always look for it. At present, Gaurav is from with us, and there is another fellow. The two of the 10 our international fellows we bring from India for additional training, and now they all want to combine with a structural, knowing that the TAVI is becoming very, very
correct.
popular there. And I know that you're centered from quite a bit, and you are leader in various aspects of intervention, and particularly various of the left atrial thrombus and innovative. So really, thank you to be a guest faculty today, and of course Dr. Jaya, which I know him peripherally. I also met few times, and thanks for to be part of it as a head of the department of pediatric cardiology, and of course, lot adult congenital and overall interventions are very goes hand in hand together. So with that note, this will be our case discussions, which will be after 1 hour of presentation. This is the case number 17 by our the Sun Pharma and Cardio Companion relationship. This patient, 84-year-old, had a known heart failure, never had a cath before, low ejection fraction, but recently presented to outside for progressive dyspnea and had more advanced heart failure and positive troponin. And the creatinine is always a stage 4, fluctuate today actually is 1.8. Patient also had an echo, which revealed EF of 21%, moderate to severe MR and TR, and a lot of akinesis and so. So with that, patient was on good guideline-directed medical therapy of heart failure as well as anti-ischemic therapy, and then had a cath. And cath was done because patient is troponin positive in addition to heart failure, which is 3 vessel and left main trifurcation disease with the high syntax score and low EF, and which Anu is going to show. Okay, Anu, let's show the fluoro, please.
So EDP was actually 14, patient well compromised on good medical therapy. This is where the echo is, yeah, LV gram. We see that always an echo has to be done in patients with low EF to understand if there is concomitant valve disease, as well as rule out any LV thrombus before we consider if we need LV assist device to be placed.
Uh,
So also this is probably giving us an idea. The antro apex barely moves, which is LED is probably old, and our patient has Q waves in the anterior leads. So the right coronary artery mid 90%, and you have a PDA also 95%. Now the patient is elderly with the low creatinine clearance. That is why we didn't do multiple pictures beforehand. And here in ideal case you would want to go to RAO view and see if there is any collaterals to the LAD, knowing that LAD is total, that is a must, and I always tell the fellows that should be done. We did not do it here. So the plan was, once you that we were going to do LV-assist device in this case with the elderly patient, low EF and 3 vessel disease. So we did place the impella, and after that we did the PCI of the RCA, 95% PDA as well as the mid RCA. We did a PCI there, and this is where we are with the. Now, could have been the culprit when he presented with the non-QMI? Could be. You see this slow flow, probably underlying thrombus there. So always give vasodilator, which we used some nitride as well as nitroglycerin, and this is the final picture what we have here. And now going to the left side. So significant distal left main disease, and your moderate size circumflex, but again ostial circumflex is involved. There are small OMs. Look, there's a ramus which has significant disease, which you will see it here better in the cranial view. So mid LAD is total, and segment probably is over 30 millimeters. So you have JCTO score of 3 there already, but you see here why we did not see the LAD from the RCA injection. You see it from the left-sided injection itself.
The ramus fills it. So just to say, these kind of LV dysfunction cases where just a very small troponin, which could be just from heart failure. So always question comes viability. And as you know, we still want to do viability, but more surgeons believe they won't take a patient without viable. They did actually the PET scanning. This patient came from outside institution, and PET scanning showed the viable inferior, infralateral, and lateral wall, and apex was akinetic. I mean, no viability at the apex. So that goes with that. LV funk, we saw it. So therefore, our goal was avoid that. Don't go after the mid to distal LAD, creatinine already high, and just go where the money is. Money is in the distal RCA and the 3 branches here of the LAD diagonal, LAD ramus, I would say, LAD ramus and circumflex, and preserve 2 of them. And we use the impella. As you know, we can put a ceiling camera, please. So single axis, which is 14 French, and that's a very good from access point of view, that you put your impella CP. Now many times you can actually use the 14 French sheath of any company, and then you can still use the regular impella, which is LP. But that you will require the different 14 French sheath, and then you puncture the side. Cannot go through the same hole. It has to be a separate puncture, so otherwise it oozes quite a bit. We learned that 4 or 5 years ago. So single axis in majority. Only disadvantage, while it's a good advantage of having single axis, is that of course less vascular complication. But disadvantage is manipulation of the guide. If you have to manipulate the guide, is always very troublesome. So more, as long as it remains in the proximal segment is fine, but guide manipulation is very difficult in this situation.
7 French.
And then because of the 7 French, 6 French is okay.
6 French, okay.
Yeah, 7 French. So this patient, if we complete, and then we'll ask both of you to comment on it. Let's go back to the slide presentation. So this case had multiple areas of viability, and had a cabbage consultation, was declined, and came here now for impella supported complex PCI left main trifurcation and RCA. RCA has been done. As you know, with the guideline, you need to do 2 things in these advanced complex cases. Calculate the STS score, because by definition, anytime your STS is more than 4, is associated with high event rate. So surgeons traditionally don't take those patients. And of course, syntax, we know anything more than 32 is associated with bad outcome with a PCI on long term. Even the trial of the left main, Excel excluded patients with a syntax of 33. So this patient actually syntax was 48, and STS score of 5.1 is appropriately declined from the surgical consultation. So if we put into the grid of our OC, left main and 3 vessel, this patient will be in the bottom 23, intermediate or high risk findings on non-invasive testing because of PET scanning viability, and with a high syntax score, more than 20. Multiple features of complexity, and M with a PCI, but more importantly, after heart team discussion, I say, so this becomes appropriate A. because the patient, you need to offer something to the patient is otherwise viable despite his age. So key is the using the Impella. Why? Somebody with a low ejection fraction, you're doing a complex revascularization. This is what is STS of more than 5 and high syntax score. You are it. There's no surgical option here. So therefore, you want to do your best chance. Now, Impala would have been one big issue about the cost. So clearly the difference in the LP and CP of about 3-4 lakh rupees. Same way here, $5,000. Then if the contraindication for Impala would be if you have associated aortic valve disease, AI, severe AI, or trauma, or peripheral vascular disease. So those cases will use a balloon pump and of course extreme low EF less than 20. Everybody, this is about 20 now. We actually have the data from the registry, not a randomized trial, that even in high risk PCI, that even with the near normal LV function, doesn't have to be severe LV dysfunction, the Impella got approval by the FDA for even patients with the complex CAD with ejection fraction is still 35%. So Impella is approved at present here. Now I know that in India we don't use that. Part of that is prohibitive cost. Taken all these together, we use about 12 to 15 Impalas per month. So about 140 to 150 Impala per year we use in our cath lab with 340 PCI. We do balloon pump in 3, 4, 5 cases per month, and those cases are basically, as we mentioned, there where Impala is not usable. So at least in America compared to India, where there is a most of the out-of-pocket expense, here appropriate case can get Impella assisted PCI and get the best outcome. And now the ongoing trial called Protect 4, evaluating this concept of the multi-vessel disease with ejection fraction less than 40%, patient being randomized to standard of care, maybe with a balloon pump and so, versus Impella. But Impella has to be CP. So with that note, we are here now. Anu, tell us what you want to do, and now we can take some input from both Dr. Manjunath and Dr. Jaya.
Yeah, good morning, Dr. Sharmaji and Dr. Kinney and all your colleagues. And it's always a pleasure talking to you. You are as enthusiastic and agile at any hours of the day. You are 24/7 interventional cardiologist. We are very happy to associate with you today. And this is a really a complex case, and because ejection fraction is just 20%, and the patient has got moderate plus mitral regurgitation, and of course I was told aortic valve is normal. Yeah. And RCA distally it's occluded, and definitely this is a case for Impella because ejection fraction is just 20%, and intra-aortic balloon pump in this situation definitely doesn't work, as you said. Definitely it doesn't work. And only issue is, yes, so this patient has only 84 years, but we don't see much calcium on the fluoro actually. You don't see much calcium on the fluoro for 84 years. And always in this sort of situation, we should look at aortic valve because some of them do have aortic stenosis. Aortic valve is normal in this case. Yep. But the LV angiogram was taken with the catheter, endole catheter, but we should not always take a pressure injection with an endole catheter in LV because it can cause perforation. And in this, it was just an hand injection because it must be a Tiger catheter. I don't know what is the catheter that was used for this. And they plan whether MR mitral regurgitation is due to inferolateral MI. That is also a possibility because circumflex is diseased and the PLV branch is gone. And so whether the question is whether mitral regurgitation will come down in severity following the PCI. That is the other thing we are thinking about it. Yeah. And regarding mitral regurgitation, what is your plan? Is it, I mean, are we going to address mitral regurgitation also, or just do away with PCI of both LAD as well as the RCS?
Yeah, so very good, important points as you have mentioned in this particular case. Clearly the appropriate of the support device is reasonable. Now you see that in order to put Impella, you need to put your JR catheter. So what we do is, even in this bad LV cases, just handheld injection 2 cc's. And actually this is what we have been teaching. The year we start doing in 2004. We have done over 300,000 and so what shows on the website, they show it on the web and media, is that they did the Tiger catheter and pressure injection causing perforation. And just to say that very clearly, so that will take the same JR catheter, and you see here 3 cc's of dye. And what our purpose there is, gives us idea about one LV thrombus, one, it's not for the valve. So therefore, this case is just to have some idea what the EDP, any LV thrombus, and how his overall ejection fraction is. Once you get into trouble, let's say if surgeons wants to know it if anything happens. Second question in this particular case is very important, and that is the mitral regurgitation. So key is that yes, the case will get revascularized, and then he was up titrated on GDMT few weeks ago in preparation for revascularization now, and then we evaluate after 1 month in terms of the TE. We need TE to see whether it's a clippable, and second is that time we do a transthoracic also, because knowing that TE always has low mitral regurg. So at that time, so we need both transthoracic and TE to see what is the degree of regurgitation, and if it is 2+, then you are done. And I expect in this case, because point is, this patient has a heart failure. We had the old echo few years ago. That time used to have moderate MR. But that time ejection fraction was 40%. But this was like few years ago. Again, this patient is first time coming to us. But we have the old finding. So I personally think that once we revascularize, his MR will become moderate and probably will not need the clip. But yes, this is the case, classical case for TR. Because surgeons are not going to take these kind of cases, and it's an appropriate case for trans catheter S2 as repair using the mitral clip. And soon other devices are Pascal and all has shown good data up to their 2 years, which is the Edward. And I was told that probably by year end, because right now mitral clip territory is very small in India, representation cost wise, and then that will likely once we have Pascal by year end will come to India also. So clearly we need a device. So here right now ischemia, follow up echo with including TE, and then decide whether we need to do the mitral clip in the future. Then he also has, say, moderate to severe TR. And I know that one of the case discussion later will be, keep going. Yeah, okay. Yes, okay, now, Anu, tell us what's happening now.
So I was trying to get into the circumflex. It's not easy to get in. So I think I'm going to use a venture catheter, and then we've already wired the ramus. So we've decided we are not going to do the LAD, so we will leave the LAD alone. So I'm going to use...
No, but LAD we should cut. There is a big septal, mega septal, and goes to the little bit of PDA collateral. So remember, no, LAD, the question comes here that what do we call I think this is okay. Here we call LAD as a side vessel, third vessel, I would say. In a trifurcation, the ramus and proximal circ are the significant two viable territory.
Circumflex is arising at a right angle almost.
Yeah, that's exactly correct. Yes.
Right.
So that is why I'm not trying to use here. No, what you get in this view, no? Yeah, very right angle, and we have the Wolverine available. There is a new device which will be coming like angiosculpt type called Scoreflex, which is just introduced here in United States, and the idea is the same, having a one additional wire while you're doing the for kind of lesion modification, atherotomy. We actually, I still think when you really need it, basically the score of our Wolverine is the best one. So now you want to go to other view to go to the circumflex? Yeah. So I think we go to that view. Yeah. Or you can pull a little bit here. Yeah. No, came back. So I think other view will be better in my opinion.
No, I could not see it.
Okay. Yeah. So key is the same. This is what we are using here is the venture. The other device.
Okay, so now that's in that other small branch.
Yeah, you are in the small branch.
In between ramus and circumflex, there is another small branch.
Yeah. So, but I would still say, anyway, you want to see it, you want to go to other view, or this view you are happy? No, but you have to pull back the wire before
Yeah,
you're
no,
angling.
wait.
This is a regular hyperflex wire?
Yeah, it's a regular fielder,
some
yeah.
die.
But again, the LED in these cases, which I say, that don't sacrifice any vessel. So you just still have to do a balloon like the flex tube of the ostial LED, so that LED and septal remains okay. They don't close. Because in these cases, that even your 1 or 2% of the myocardium, once it jeopardizes, gets into trouble. Undo and bring it back, and let me go to the better view. Ready?
Not yet.
Okay, 1 second.
Yes, that same branch, I think.
Yeah. Okay.
That's
Can we go to, yeah, the same
wire memory.
always happens that way, yes.
Yes.
No,
Probably the
they're not
support
close. Okay,
catheter
1
has to
second.
be withdrawn a little bit.
Further, yeah. It has to go further down. Okay, 1 second. Can we go to different view?
It doesn't show it well. Okay, you can go to a different view,
Okay,
but you
just,
don't see it.
yeah, and 1 second. So what we need to do is this view. If we go here,
No, don't see it. Okay.
yeah, so,
Don't see it.
no, 1 second. Yeah, so let's try in this view. We go, but key is that wire still has to go into the
Move the
top
camera.
branch. Yeah. LAO 10 and 38. Okay. Okay, we are to this view now. Okay. So now question is where the wire has to be advanced first. Good. Good.
Can you give some dye?
No, but you have to pull back the wire in the, you cannot rotate well there. So many times the venture or supercross, they'll point in a different direction. So then you rotate. Yeah, good. Yeah. Another question is that you use a stiffer, your Gaia 2 or Miracle into the distal area.
Can a whisper also be an option?
Yeah. Yeah, whisper. Yeah, let's get a whisper. Actually,
I'm not doing whisper.
thinking about the whisper.
Get
Yeah.
me a supercross. Yeah.
Okay. What you're saying, go independent. Bring back in the guide and just go with the wire in this view.
No, it does not go. Tried.
No, in this view now.
No. I started with this view.
Good.
Okay, get the supercross.
But on 120, do we exchange length whisper also?
You have to give an acute bend to the wire tip, maybe.
Yeah. So, yeah, I mean, actually, the,
We don't need exchange length whisper. Give me the regular fielder is good enough. You have the supercross?
okay. So we now going with the supercross and the whisper wire making a little extra curve.
I'm not.
Yeah.
I don't need.
Yeah. This may require a little stiffer, because of that angle. And with there, I would say the Gaia 2 will be very good. But go with your things first.
I'm not.
Yeah.
Get the fielder. Not doing this.
The fielder wire.
We had.
Yep. Now, what is your comment and use of Impala at
No,
Jayadeva?
definitely, sir. And yeah, actually, this sort of cases, there is no other option because surgery is ruled out because of age, ejection fraction, and all. So this is I mean, if at all, if you are doing this sort of cases, it has to be done with Impala alone. Otherwise, it should not touch without Impala.
Absolutely. Very good point. So that I would say exactly is the cases that once you need to go to
Where
this
is
level.
This, white thing to go inside. There, no? How do we go inside with this now?
I'm not seeing fluoro.
Yeah. Now we are going to get on the fluoro, yes.
Dr. Sharma?
Yes.
I am basically a pediatric and congenital heart cardiologist.
Yes. Get
So I
into
can't contribute much to all these things, but I'm enjoying the show.
Yes. Yeah.
And I think, I mean, we do a lot of PDA stenting, a lot of other collaterals, so many things in congenital heart disease.
Advance the
I
wire.
think we use a lot of whisper. Whisper does come
Tell
to
it
your
not to
help, but
open another
times,
supercross.
Yeah.
90-degree bends and all in kids.
Yep.
Yeah.
We are going to try the whisper here. Go. Okay. So let's see. I'm going to open this little die. Now there is another exchange catheter which is not available in India. I mean here, the Ninja, right? Shaft Ninja. Yeah.
Die.
Yeah. Good. Swift, called Swift Ninja. You want to take a little better picture where you are? Good. Yeah. Okay. Now what? Exchange length run through.
Run
which?
through.
Yeah. Exchange length run through. Yeah. So we need to go to good. Yep. This is the large one. Okay. In the end, we should show the imaging, no? You have something?
No, nothing.
I was in the end,
No need.
not OCT. Yep. Okay. So now we have both wires, one in that ramus, another one in the circumflex. And when the time will come, we'll do a little cut with the ostial LED. What balloons we have at present ready? Okay. So we can use a Wolverine 2.5. Yeah. Good. Yeah. Let me open this. Yeah. So always one of the big disadvantage I see with the superflex, supercross is that the wire tend to come back, and particularly if you have second wire, even that wire comes back. But anyway, so careful. That's what we did here. Okay. So we have the Wolverine 2.5 to all the branches. Good. Okay. Do the circumflex first. And then, in this case, knowing that you need to, it's not a case for provisional. You need to have a good results of the bifurcation. There's a little bit of a significant distal left main. So with this case, we'll go with the mini crush. I know a lot of people in India, DK crush. We actually have been teaching, favoring mini crush. Very rarely we do culotte. And that's what will be the plan in this particular case.
Can you see fluoro?
Yeah. Go on fluoro. We are coming on the fluoro now. Yep.
Go up here. Ask him if there is a video of
good.
the mini crush of the left main.
Okay. So this is the
Actually,
2.5.
there is
Yeah.
a
Down.
huge step down from LMCA to LCX
Yeah.
or LMCA
Yes.
to RAMAS.
Yep.
So normally,
Good. Yeah.
the
Going on.
proximally we have to land exactly at the LMCA junction. LMCA
No, I think
to
we'll bring it
RAMAS
to the
junction.
mid. The same, actually, but the 3.0 proximally can be made up to 4.0, huh?
Few millimeters.
Yeah,
away.
then
Yeah, few
not
millimeter,
post
yes.
Yeah,
dilation.
not.
Yeah. Post dilate. Yeah.
Okay,
Yeah.
good. Go
Yeah.
up here.
Yeah. So the Wolverine, you can always go
On.
to 16 atmosphere.
Okay.
Good. All right. Good. We don't need to
Pull,
see anything.
don't
Yeah.
pull the wire.
Uh-huh. But same, we'll go into the AP cranial view after we have done the atherotomy of both the circumflex and the ramus. Just to open, no, we use this again. Just to do, open the ostial LAD, because once you have done it, you don't want to come back and go to the side branch. And purpose there is not to go to the mid LAD. There's a proximal LAD with septal, and that we know that it supplies good collateral to the occluded distal PDA. Okay. So now we are going the same into the ramus. 2.56 Wolverine.
Yes, sir.
Yep.
Be complaint.
So far, no patient, yeah, the no same Wolverine balloon, our the cutting balloon. So yeah,
Good.
2.5 only.
Yeah.
No, just
Good. Go up here.
there. And, yeah.
So you have a 2.5 down.
Hmm.
Are they?
Is there any grating sensation when you are
No,
moving
no.
the
We're good.
balloon down?
Yeah.
Good.
Ready?
Yeah.
That means there is
No.
no significant
Calcium.
calcification.
Yeah, that is correct. Yes. And you are right actually that this age, this patient did not have that much calcium. I mean, can you imagine at this age? But that's some people are, and otherwise we have people at the age of 30 severely calcified.
See, here also in India, we see their children do have a lot of calcium in
Lot of
summary,
calcium.
not
Yeah.
the grandfathers.
Yep. Are we done in room 6 or no? Yeah. Yep. Okay. Good. So now let's see here.
Sharmaji, if you
Yeah.
look at
Yes, yes.
LED, the
Yeah.
LED moves, is moving well.
Yeah. Right. No, the proximal LED. So we are going to go back
Yes,
to
yes.
that
I'm
proximal ostial LED cut only.
No. The
Yeah, here.
thing is,
Just cut. Remember for the septal.
if you dissect it,
Yeah, that's
this
okay.
could stent
But no,
thrombosis
will
later.
be okay. We have this wire additionally here. Just cut there.
LED is moving reasonably well. That obviously there should be some good viable myocardium there.
Yeah.
What is
Good.
this?
This is the whisper. We have it. Yeah. Okay. So we're just going to do a cutting, but key is the same. That no three vessel. That basically the trifurcation we are making into the bifurcation. View is 2534.
Okay, get us a 3 or 16 and a 2.5, 12.
Yeah. 2534. Try to do just go to the same view so that you don't give too much dye, particularly in this patient where creatinine is moderately elevated, CKD stage 4. This is the same cutting balloon. Do you want to run through? To bring the guide a little bit in.
Like this wire.
Good. Very good. Let's go to the septal. or anywhere. So now with the same whisper wire, we are using into cutting the ostial LAD. And then we'll take the wire out. Okay. Stent approach, we already have decided. We are using, but Promus 3.5, 16 and 3/12. Okay.
Not 3.5, 3.0. 3.0, 16 is good.
And 2.5?
Yeah, 2.5, 12 to the Remus.
Okay. So Remus will be a 2.5, 12 and 3.0, 16. We are using a Promus Elite.
Oh, you want a little more.
Huh?
20.
Longer. Circumflex should be longer.
But then we'll cover that OM.
No, don't cover OM, just
Yeah, but no,
proximally.
20,
Yeah.
maybe too much, I think. Okay.
Yep.
Give us a 3.0, 20 then.
Yeah. Good. Okay. I'm going up.
Okay, down.
14.
That is just ostium you are addressing, right? Ostium.
Yeah. Good.
Pull back.
Yeah. The same back and forth few times. So trying to cut in a different direction.
Do the left vein also. Oh, there's calcium. Go up here.
Yeah. I can tell you the first time the blood pressure has gone down. It was never went down with the individual dilatation before. This is with the Impala. You see the hemodynamics before there.
Give 1 cc dye, not
Okay.
a lot.
No, wire.
Oh, yeah, wire came back. Because the guide moved.
LED wire is into a very small septum.
Yeah. So again, we never went further down. Good.
That's
You want to go with a little more in the LED work, or you're happy?
Leave it. I never wanted it anyway. Okay.
Okay. Good. Okay. So let's decide now. Good. You want to see it, what you have in terms of stent size now? We are ready for here. And we actually have the Bifurcate 3D app. We're going to talk about the side by side. We'll have the mini crush technique. Okay. So we actually have the 12, 2.5 and 3/20. You want to go to different caudal view, I think.
No, this is okay.
Huh?
I think this is good. This view is okay.
Okay. All right. So let's get the stents then.
Okay. 2.5, 12.
2.5, 12 first. Yeah.
Yeah.
Ramus, you are using 3.1?
No, yeah. Actually, the circ to the main will use a 3.0 and 2.5 here. And then, of course, we always will do a KT. Yeah, exactly. So we can want to show the
Bifurcate 3D right now.
Show the Bifurcate 3D now.
We don't need to show the hemo.
Yeah, take away the hemo and show that. Good. Okay. Promus. So the reason, knowing that in India quite a bit, there's a big, I would say, push for using a synergy. Any region not using synergy? No, to our audience, Indian audience there compared to Promus?
Nothing. Is the stent that you are very comfortable with. That's it.
Yeah. Yeah, so key is that there are some data where original burns registry, there's some higher stent thrombosis into acute with a synergy because there is no drug on the abdominal surface. But that actually, we publish our own data. We did not find that. Since then, there have been a few other reports. But yes, there was a concern at one point of higher acute stent thrombosis in the synergy. Okay.
Is
Done?
it playing?
Out. Yeah.
Is it
Good.
playing?
Yep. Okay, playing, yeah. Yep. Yeah. Okay.
Now some dye there, yeah. Good, right?
Good.
Wait.
Okay.
Hold on.
Yeah.
Now. Okay, take a cine.
All right. Very good. Very good. 2.512 in the ramus.
Okay, go.
And 3/20 there. Good.
Yeah.
Fluoro. So we're going to the ramus first.
Yeah.
16 atmosphere.
Good.
Not yet. Not yet. Not, we have to take out everything.
Down.
So same as we playing the below. There's a classical anatomy. So take your wire out
Some dye.
and just to see little fluoro only.
Where is my wire?
To see that there is no dissection. We need to take care. You take care now. Good. And remove the wire. And now we are ready with the stent.
Yeah.
Good.
Go.
Going up now. And use a 2.512 balloons and so. 2.5 and 3.5. 8. 3.58 and 2.512. Yeah. Now pressure definitely went down, which is expected. So now this is the lifeline completely. So this is what I say, that we're using this support device for these few seconds of inflation. And so, okay. So balloon has been done. The wire was removed earlier with the mini crush. You don't want to leave it. Some people say, well, we can leave it. But overall, we know the leaving wires in a side branch is okay.
Yeah.
But if you have a stent, then we don't. So what is your practice,
No,
Dr.
sir,
Manjunath?
we will also, yeah, we'll definitely will remove it. Otherwise,
Yeah.
sometimes
Yeah.
it's very difficult to take it out and it
Yeah.
gets stuck. There
Exactly.
could be the
Yeah.
wire
Could be
gets
trouble.
damaged, and also
Yep.
it can be broken.
Yep. Good. Let's take a picture now. What happened to this wire?
Want to advance the regular
No, but
wire.
go with your this wire first.
No, this wire.
Yeah.
Other
Good.
wire has come out or what?
No, but let's take a
No,
picture.
I'm taking that wire out. Because that was the 300 wire, so I took that out. And the side branch wire, which was 180 wire, which was run through, has gone into the main vessel now. So
Right.
we'll recross.
And you have the whisper wire there, so we can take that whisper wire. So this we remove.
Not whisper, give me a fielder.
Yep. We have it here.
We have a good new fielder we have a fielder there? Get me the fielder, yeah.
Yeah.
See,
I'll take
normally we have to take out only the ramus wire.
Side branch
and
wire.
L6 wire. Yeah.
Yeah.
Side branch, but
Yeah, the
main
same.
vessel wire also has
Yeah,
come
main vessel. No, main vessel. We just changed it. We didn't come out. We just changed the wire. Yeah. Good.
So
Let's
we
take
have
a
to
picture
recross
now.
then.
Yep. Ready? Good.
The main vessel had a 300 length wire. So that's why we
Okay.
removed it and put the side branch wire, which was
Good.
180 wire into the main vessel.
Okay.
Now I will recross with
No.
another wire to the side branch, which is usually I like a polymer jacketed wire, which will be have fielder here. The one we used earlier, the same one will go in.
Okay. So now we have
now,
2.5 balloon.
Other thing is left main, don't you need a 8 millimeter?
Yeah, 3.58. We have 3.58 for the left main. Yeah, left main. And then in the end, we'll just do the IVAS to show
Okay.
that full expansion. Yeah,
Why you
in the
have
end.
this view? That
No,
view
this is better now. You'll see the ramus here.
No. Better one.
Do you want to go to epicranial view? Or you want to go to same view?
Okay. We need to go with the 2012 balloon first.
Okay, 2 or 12. Once we cross, we are 2.5 right now, right? Compliant? No, we are high pressure or compliant? No, you need a compliant balloon. Once you have done this kind of mini crush and vessels are small, you have to go to a small balloon first. 1.5 or 2, and then you do your kissing. Okay, you want to change the view?
Yeah, go back to the other view as I liked. Okay, get me a 358.
Yeah, we have it, 3.5. So many times what we say is that you need to do a pot now if you cannot get a wire into the side branch. So a lot of people will do the pot irrespective. So we basically say that do a pot at present and to help you to facilitate into the side branch, and then of course you do a kissing. Yeah.
This view 029. Okay, get us 358, right?
Good. Okay. Yep. So same. The left main, distal left main, we know that it was a big vessel anyway. And we ask our audience also any questions in the chat box. We are fully available to answer.
Your left main is almost 4.5, right?
Yeah.
4.
So if need to be, we can bring it further because this was just in the distal left main.
Go.
Ready?
Okay, yeah.
24. You want to go 2 millimeter further?
Okay.
Yeah, good. Okay.
Okay. Good.
16. Okay. So pull back and you want to put your wire. And take this out or what you want to do? Okay.
This is 3O balloon?
3.5.
3.5.
358
Yeah.
millimeter. We went up to
26.
Yeah, 26 atmospheres.
Keep it this one. We are going to need this again. Okay. Now the key is here, recrossing. And the whole science, whether proximal cell or distal cell, proximal cell in the DK crush, distal cell in the mini crush, you need a new wire. Wire is destroyed.
No, this is new wire. No.
You hear the whisper? Want to magnify you a little bit? And if you need a balloon support,
Yeah, we may need a balloon support. Why is he moving?
Had it not been a 300 centimeter, I mean, wire, probably. Yeah, no.
No, this is not
Two
a
of-
300. It's a 180.
180.
No, earlier. Had it
Yeah,
not been
earlier.
300,
Yeah,
it would have
yeah.
been left like that.
Yeah,
no,
yeah, 100% agree.
no, but not left like because
Yeah,
remember.
it was in the main vessel. He's saying in the main vessel.
Yeah,
the
main
300
vessel.
wire
Oh
would
yeah,
have left
main
it,
vessel. Yeah,
Not in the side
but
branch.
not the side branch. This is what? It's a 2O12 balloon now. We're going compliant, knowing that it will be tough otherwise.
That's the teaching we always say. The main vessel wire remains, though many people want to say that you can swap. You know, the main vessel wire, you can go into the side branch, and the side branch wire that you took and that is sitting in the guide, you can use it in the main vessel. As long as you know the tip has not moved. But we usually don't do that. We will just leave the main vessel wire and use the side branch wire that was previously used, which is in the guide again.
Yeah, many times taking that, as you said, if you withdraw the wire from the main vessel and get into the side, daughter vessel or the side vessel.
To the side branch,
then you start, then you start putting the wire into the main vessel. There can be a kinking also.
Yeah.
Yep.
Down.
Crisscross.
Now we wanted 2.5,
Yep.
right?
Yep.
And what?
3.5 again. That's it.
This is a 2.0?
Yeah, this is out. No, out. We are 2.5 and 3.5. Yeah. We just do a kissing balloon and then.
Now, before we go higher pressure in the left main, let's image with IVUS. If we need, then we can post dilate with the 4.5.8.
No, but your kissing, you'll do both of them. Will be like 4.5. That's okay. Let's do the kissing and then we do the IVUS in the end. Good. So let's get 2.5.
Any questions
Yeah,
from the
2.5.
audience in the chat?
Can we just have a stunt boost when the balloon is in? Just
Okay.
of course.
Sure.
We are doing,
So get the stent boost. Yeah, no, we'll show the stent boost. Yeah. So right now we are going with a 2.5 non-compliant in the ramus, and we'll have a 3.5 balloon which we had earlier. Good. Into there and do a kissing balloon, and before kissing balloon we'll do the stent boost. This is 3.5. Yeah. Are we good with the stent boost? Okay. Once we get but you cannot have both balloons. And the stent boost will not come. No.
You can. You'll not see it well, but you can. You don't see it well. We don't use a lot of stent boost here.
Yeah, because of higher radiation. Or?
Well,
High
yeah.
radiation.
Yeah.
And our eyes have so used to just doing it
Okay,
fast. Yeah, we
Okay.
Hold
don't
it.
go.
Yeah.
Even a little extra radiation is too
Hold
much
it.
for
Hold
us.
it. Hold. Pay attention. Good. Good.
Okay.
Ready?
Go up.
Yeah. Okay. Now 1 second. Do the stent boost first.
Oh my God. We need
Sina.
to call somebody to do the stand boosts. Okay, that's it.
But they cannot see it there.
Oh,
I think,
Stand boost. Come. Okay.
yeah,
Floor.
yeah, we
Yeah.
can't go up.
But
You
looks
can't
good.
see it. Yeah,
Yeah.
good. Go. No, don't rupture the vessel.
Good. Diagonal, right?
Okay, yeah.
You can go
In
to high
fact,
pressure.
we are
Yeah.
doing fluorosave. Did you see the fluorosave? Yeah, good. Down. Not radiation. Down.
Okay.
No, I want to come back a little bit
Yeah.
and do here.
Both of them same level.
Yeah, but don't go to
Yeah.
crazy pressures. Okay, good.
Good.
Yeah.
Okay.
Okay, Ivers is ready.
12. 12. 12 both.
Good. Enough. Enough. Okay.
Negative.
Down.
Okay. Let's come back in the guide and take a picture because we have not done the picture yet.
Let's do the Ivers SS.
Okay.
Elderly patient with high creatinine, avoid dye also.
And look for a 4.58 in case we need further optimization of the distal left main. We'll do with a 4.58. Good.
Keys here?
Yes.
Okay.
IVUS is not attached yet, right? Is attached?
Yeah, they have.
Okay. We'll do the IVUS and then show on the angiogram. We are not, as you saw it, we haven't done even fluoro or anything else here. And we'll predict based on the IVUS how angiogram will going to look. And yes, one of the issue has been with the creatinine, with the OCT, and I know a lot of people do with the dye-less on the
You still
saline,
don't see it very well.
but it's always a issue, particularly right coronary.
Yeah, saline also with an ejection fraction being as low as 2%.
Yeah, maybe a trouble too. Yes. Good.
So we are going into the main vessel.
Sir.
Okay,
So
Kiski, you
check
can
the
see?
image. Yeah.
Yeah.
Now it's
Start.
outside of
Yes.
stent. So start to work. Yeah. Here is a normal part. Not much plaque. Coming back. Some small branch. Still outside of stent. Yeah. Not, a little bit plaque. Like yeah. This
Okay,
is
you
the
see the
distal. Yeah.
stent.
Looks good on the plaque, but looks very expanded. And no dissection. Expanded. Looks good. Coming the branch. Bifurcation. Trifurcation. So it looks like the left main. Still interest stent.
I think
Yeah,
it's
looks,
well opposed.
Yeah, expanded.
Yeah,
Expanded. Yeah,
well
looks
opposed.
perfect.
Yeah,
Yeah.
expanded,
And
well
no
opposed.
knowledge dissection.
Give us a CSA of the left
Okay,
main.
sure.
Yeah,
Good.
and the circ. Yeah.
And the proximal left main is very big vessel, 5.
And
Yeah,
no plaque. Okay, I checked the time.
4.5 almost.
Yeah.
So this is the distal edge. Looks good. No dissection.
Come back to the left main. Give
Sure.
us a CSA there.
So, yeah,
yeah,
so
they're
this
right
is
there,
a-
right there.
Yeah, a little bit elliptical shape, but looks area is huge. Yeah, like 12.
Okay.
It's
Yeah,
a left main.
Good.
All right, go back to fluoro. Let's take the picture because we are reaching to our 10:30 mark. I mean, or from
I'll take out the
point to
wires.
there.
Okay.
No, just take a picture first, no?
Okay.
Branch is there. You want to give a little vasodilator. And the last picture, always we say that take a low mag. You see that? You want to
Okay,
make sure
come
that LED remains good.
Actually,
Yes.
blood pressure has gone up after the PCI. You can start weaning the impeller. We're giving some vasodilators.
And we'll remove the.
What is the vasodilator used, madam?
Yeah.
We use some nitroglycerin as well as nipride. Nipride I gave 100 mics and nitroglycerin 200 mics.
I think the nitroprusside works very well.
Yeah,
Yeah.
nitroprusside, yeah. Now, adenosine, a lot of people use adenosine, but we are not
Ready?
happy with
Ready?
the adenosine. Yeah, guide, hold the guide. Yeah,
Yeah. That's
Yeah.
In our lab, we more often use nitroprusside.
yeah, exactly.
If there is no
Yeah.
response to
Yeah.
nitroglycerin, nitroprusside works
Yeah.
very
good.
well.
It looks
Yep.
okay.
As you see here, The purpose of the LED septal remains. Yes. And guys, just can put this one on the main screen completely now. And our ramus remain very good. Circumflex with all the branches remain very good. And so you can take us off and just, so angiographically, what our mission was, we have accomplished that now. And Floro, you can just show the angiogram last and then we go on. Yeah. They cannot bring the angiogram alone on the main screen.
No, they cannot. Leave it.
Yeah. Okay. Sorry. Yeah. So this is what we have. All the branches.
Keeping that septal, intact is very important.
It's still there. Yeah. Yep. The
Septum
idea was otherwise we know would have gone.
Yeah. Septum contributes a lot to ejection fraction.
Yeah. Oh, absolutely. And particularly the septal supplying the collateral to the PDA also. So that septal we saw.
Yeah, that's good. And then
that supplying the collateral to the PDA.
3D. Show the bifurcate 3D.
Yeah.
Yeah, this is good. Leave it there.
It is so delayed. Further down a little bit. Okay. So we're done with our procedure point of view and hope for
one slide with the app. No.
All the and then we're just going to go over our latest of the cardiology apps.
So
with the
what
multiple,
we showed,
you start doing your things.
when we were doing the
It's a great
bifurcation.
pleasure, sir, watching you and Dr. Kinney. Really, the ease with which you did this bifurcation and decision making was fantastic because it was just a trifurcation, but most important importance was given to the LCX and ramus because those were the live vessels. And LED, as we saw on angiogram, the apex was not moving. So the viability was more in the lateral and little bit anterolateral wall. So that's the ease with which you crossed circumflex was really a great teaching thing because circumflex was dropping at 90 degrees from the left main. And without compromising that septal, it was very good teaching. We learnt a lot from this, sir. And I just, of course, MR is probably might have come down by at least 1 grade, the way the vessel is flowing. And we wanted to know this impella, you think, we should keep it a little longer or we want to take it out once the procedure
Most
is done?
often we take this, all this, what we would say, which require a complex vascular access in the cath lab at the end of the procedure, since it will be done under fluoro. Right now we will take the impella and as well as the closure will be meticulously done. So the biggest issue with this, support device is always, how you get a vascular access. Large bore access is very important that you do under fluoro access as well as removal. So now the patient, you saw that very little hemodynamic compromise, only except when we did the LED or left main. He's stable. And we knew the EDP was okay, so we are end of the procedure right now. We'll take out the impella and close it under fluoroscopy, so that we know we have a good distal, the vascular bed will be good. Peripheral vascular.
So what is the occlusive device used? You use a ProGlide or Angiogram?
No, this is a ProGlide per close, 2 per close. Pre-close has been done. You do so 2 pre-close at opposite sides, and then they will close it at the end now.
Yeah, bring the camera there so they can show the 2 pre-closes. Yeah. So this one will be.
No, okay.
Yeah, they'll do top camera. Yeah. So they'll just show overhead. Yeah.
Overhead camera.
They're going to show. Yeah.
Go down to the groin. Not that way, other side. Other side.
No, you go further.
Put your hand there, Isha. Yeah. Put to the other side. Yeah. Yeah, right there. Yeah.
Yeah.
Go now. You go down.
Yeah.
Focus.
So those are the 2. But yes, a lot of people will use a 1 per close and then angio-seal. 8 French angio-seal, which is not uncommon. That we start using it in the TAVI cases also. That use 1 because this requires a little extra finesse. But to keep it simple, 1 per close and 1 angio-seal is obvious. And we leave only in cases with the patient with a cardiogenic shock, we'll leave the balloon pump. But otherwise, all our elective high-risk PCI like this, the impella comes out invariably.
We just wanted to show you this apps. The one that while I was doing mini crush technique, the 3D animation was from Bifurcate 3D. So this Bifurcate 3D, there is a web web app as well as you can download it both either Android as well as iPhone. And then other latest one we have is GuideWire. All these wires that we use, there are over 150 coronary wires. So we have a nice library as well as some case studies to show which wire to be selected for which cases, and understanding the principles of each wire, especially for CTO. That's been nicely described in this app. If you don't want to download the app, we have the web portion, which is the website. You can go to the website and learn everything about the wires also.
Okay, with that note, both Dr. Jay and Dr. Manjunathan, we complete our today's live case presentation from Mount Sinai, and we thank Sun Pharma and our cardio companion to give this chance, and we'll continue our monthly series. And now, okay, you present, you have your case discussion, and I'll join you in next few minutes.
Thank you, Dr. Sharma and Dr. Kinney, for a nice case. I think we thoroughly enjoyed it. Yeah, thanks a lot.
Great. Bye-bye.
Thank you.